Hello everyone, let's begin with this module on ECG interpretation. Well, ECG interpretation is actually a very simple module. All you've got to do is to understand the basic concepts and apply these concepts while you are interpreting the ECG in a stepwise sequential manner. Now about ECG reading, ECG reading for your entrance exams is quite different from the actual scenario that is in your clinical practice. Because for your entrance exam, you have got a question, a snapshot of the ECG strip and 4 options, and you have got to make a quick, accurate diagnosis. But when it comes to clinical practice, apparently you are at more ease. So you can take your time to have a slow sequential interpretation of the ECG. You can debate with your friends, you can argue on certain findings. So there is always time on the other side, but here you have got to be quick. Now I would always advise that ECG reading has to be done in a stepwise manner. Well, you should have a spot diagnosis ability also, but if you rely only on your spot diagnosis ability, then what happens is sometimes you might miss on certain findings. Because an ECG can have more than one abnormality. So if you quickly look at the ECG of a patient and you find some striking abnormality, you might prematurely make a diagnosis, whereas in actual scenario there might be more than one abnormality in that ECG and the diagnosis might be something different. Okay, so which is why I would always advise go in a stepwise manner. But for your entrance exams, you have got to be quick. Now, how will you become quick? It's through routine practice. When you see ECGs again and again, when you discuss the ECGs, and then you practice ECG questions also, things actually look very, very simple. Okay. All right. So let's move on to the steps of ECG interpretation. Okay, steps of ECG interpretation. Well, I have listed below some steps, 10 steps of ECG interpretation. In fact, it is 10 plus 1, including the miscellaneous one also. So it is in this order that you have got to sequentially interpret an ECG. So let's see what are these steps. The first 4 steps are pertaining to standardization, rate, rhythm and axis. Whereas the subsequent 6 steps are with respect to waves and intervals and complex in the ECG. So you have P wave, PR interval, QRS complex, ST segment, T wave, QT interval. Okay. So these are the steps. And finally you have the miscellaneous one also. So in miscellaneous, by which I mean, suppose if the patient is having some chamber enlargement, maybe some left ventricular hypertrophy or RVH, or maybe some other abnormal waves like say an epsilon wave is there. Okay, so these are the miscellaneous aspects. Okay, now we will discuss regarding each one of this. Okay, each of these sequential steps we will be discussing in detail and starting from the very basics so that you are very, very clear on this. Okay. So let's begin with the first step of ECG interpretation. The first step is standardization, checking for standardization. Okay, you have got to check for standardization of ECG. Check for standardization of ECG. Now to check for standardization of ECG, you have got to look at this particular signal that you will see at the left hand side of an ECG, which is called a calibration signal. Okay, which is called a calibration signal. So you have got to have a look at the calibration signal to decide whether the ECG that is given is adequately standardized. Now what is this calibration signal and what is this standardization? Standardization means in normal scenarios, 1 millivolt signal, okay, in normal scenarios should actually produce 10 mm vertical deflection. Okay, 10 mm vertical deflection, and that is referred to as normal standardization. So normal standardization means 1 millivolt signal producing 10 mm vertical deflection. So how do you identify whether ECG is normally standardized? You look at the calibration signal. Normally the calibration signal should have a height of 2 large boxes. Okay, it should have a height of 2 large boxes. So the height is that of 2 large boxes. Okay, and the width of 1 large box. Okay, so look at the calibration signal that you have here. The height is, you can see clearly, 2 large boxes, and the width is again 1 large box. So you can say that this is normally standardized, okay, which is very, very important. Now why is this very important? I'll just tell you. See, you are having 3 examples here, A, B and C. So in A, the standardization is normal standardization, and you look at the morphology of the QRS complex, okay, and the example that is given as B is a half standardization, okay, is a half standardization. So when you have a half standardization, look at the amplitude of the signals. You can see it is a miniature form. And similarly, the third example is that of twice normal standardization. Twice normal standardization. So where you can see the complexes are again very large. So if the ECG is not adequately standardized, the deflection for 1 millivolt can either be above 10 mm or below 10 mm. That can interfere with your reading of ECG. Okay, which is why it is very, very important to check if the ECG is adequately standardized or not, because otherwise you can make errors. Okay, so I hope you understood what this standardization is. The next step in the interpretation of ECG is the assessment of the heart rate. Okay, assessment of heart rate. Okay, so assessment of heart rate is actually very, very simple. So when you think of ECG recording, the conventional ECG paper recording speed is 25 millimeter per second. Okay, 25 millimeter per second is the conventional paper recording speed. And with respect to the conventional paper recording speed, you have got to know a few basic values. Well, this basic values would actually change if you are recording at a different speed, like 50 millimeter per second. But for the conventional paper recording, let me tell you, 1 small square, okay, 1 small square is corresponding to how much? It is corresponding to 40 milliseconds. 1 small square is corresponding to 40 milliseconds. 1 large square is corresponding to 200 milliseconds. Okay, 1 large square is corresponding to 200. You just multiply it by 5. So that is 200. 40 into 5 is 200. Now, see, when you take 5 large squares into consideration, 5 large squares, that will be 200 into 5, that is 1000 milliseconds. 1000 milliseconds, so you can say it is a 1 second. Okay, 5 large squares corresponds to 1 second. Now, when you take a ECG rhythm strip, we know it is the lead 2 that is running, you have got 10 seconds. So, corresponding to the rhythm strip, the 10-second duration, what will be the number of large squares in a 10-second duration? You have got to multiply it by 10. So it will be 50 large squares, okay, that is corresponding to 10 seconds, correct? 50 large squares corresponding to 10 seconds. So if you take a whole minute into consideration, 60 seconds. So that means how many large squares will be there? Multiply it by 6. So 300 large squares. 300 large squares is corresponding to 60 seconds or a minute. Okay. Now this 300 large squares will be equivalent to how many small squares? 1500 small squares. Okay, 1500 small squares. All you have got to do is multiply by 5. So 1500 small squares. Alright, this very basic is clear. So let's try to calculate the heart rate. So heart rate, well, how is it calculated? You can calculate it in two ways. Both are essentially the same method. So one method is to calculate the number of large boxes between two subsequent R waves. Okay, this I am talking of in a regular beating rhythm. Okay, so 300 divided by number of large squares in the RR interval. Okay, number of large squares in the RR interval. So that is one way of calculating. So which means if between two RRs, because RR is actually that interval is corresponding to a beat, correct? So 300 by 1 is equal to 300. If it is one large square between two R waves, it is 300, that is going to be the heart rate. If it is two large squares, it is going to be 150, 3 large squares 100, 4 large squares 75, and if it is 5 large squares, it is 60. Okay, it is 60. So that is how you calculate based on the number of large squares in the RR interval. Okay, now the second method, again I told you essentially the same. It is 1500 because here you are taking into account the small squares divided by number of small squares, okay, in the RR interval. Okay, that means if there are 5 small squares, then it is 1500 divided by 5, which is equal to 300. Then if it is 10 small squares, it is 150, and 15 small squares, the rate comes to 100 beats per minute. So these are the two methods of calculation of what? Calculation of heart rate. Now remember, there can be a scenario if say a patient is in atrial fibrillation, irregularly beating. Now in such a scenario, okay, when the heart rate is actually irregular, then how do you calculate the heart rate? Okay, then you cannot take into consideration that all RR intervals are same because it is varying beat. So in such a scenario, what you have got to do is think of a scenario of a varying RR interval. So here you have got to take the lead 2, that is the rhythm strip. So you take a rhythm strip, okay, 10 seconds, and find out how many R waves are there. Okay, so you find out how many R waves are there in the 10-second interval. Okay, in the 10-second interval, you find out how many R waves are there. Now, once you have found out how many R waves are there in the 10-second interval, you multiply it by 6 because you have got to take 1 minute. So that will actually help you find out the heart rate in case of conditions like atrial fibrillation from the ECG. Okay, so I hope heart rate assessment is clear. Alright, so the next step in ECG interpretation is rhythm analysis. Okay, rhythm analysis. Now coming to rhythm analysis, you take the word rhythm. Okay, rhythm. Now what determines the cardiac rhythm? It is going to be the pacemaker. Okay, the pacemaker of the heart that is going to determine the cardiac rhythm. That is, in the cardiac conduction pathway, you have the SA node, then the impulses going to the AV node, bundle of His, the bundle branches, the Purkinje fibers. So which portion of the conducting system acts as the pacemaker, that is going to decide the rhythm of the heart. Okay, so normally you know that the SA node, okay, is going to be the cardiac pacemaker, but in certain disease states you can have, say, your AV node taking over the function of pacemaker. Maybe you can have scenarios where the Purkinje fibers they become the pacemaker. So depending on which is acting as the pacemaker, the rhythm actually varies. Okay, alright. So I hope that is clear. Now when you take into account the ECG recording, so you are seeing in figure the various the leads used for recording. So always in ECGs for rhythm analysis, you will have a long lead 2, okay, a long lead 2 recording, so which is at least taken for 10-second interval, so that you have a good analysis of the ECG rhythm. So the long lead 2 is actually used for the ECG rhythm analysis. Okay, alright. Now let us move on to the various cardiac rhythms. Okay. Now the first rhythm that I am going to teach you is sinus rhythm. Okay. The first rhythm is sinus rhythm. So let's try to understand what is this sinus rhythm. Most important point that you should know is that in sinus rhythm, sinus, the SA node is acting as pacemaker. Okay, the SA node is the pacemaker in case of sinus rhythm. Okay, the SA node is acting as the pacemaker. Now, what will be the ECG characteristic of a sinus rhythm? Well, you have an impulse that originates in the SA node and then it conducts down through the conducting system, AV node, bundle of His, bundle branches, Purkinje fibers. So something that is quite clear is that every P wave will be followed by a normal QRS. Okay, so in sinus rhythm, each P wave will be followed by a normal QRS. Okay, alright, so that is a sinus rhythm. Now sinus rhythm you can further subdivide into 3 rhythms. Okay, you can further subdivide into 3 rhythms, A, B and C. So what are these subdivisions? Number 1 is going to be normal sinus rhythm, normal sinus rhythm. Okay, number 2 is going to be sinus bradycardia, sinus bradycardia, and number 3 is going to be sinus tachycardia. Okay, so these are the 3 subtypes of sinus rhythm. Now why is there such a subdivision? Well, this subdivision is based on the rate of depolarization, that is the rate of ventricular depolarization. Because you have the impulses coming from the conducting system and based on the rate of depolarization it is divided. So for normal sinus rhythm, see the rate of depolarization will be 60 to 100 per minute. Okay, whereas in case of sinus bradycardia, it will be less than 60 per minute. Whereas for sinus tachycardia, it will be more than 100 per minute. So this is the subdivision: normal sinus rhythm, sinus bradycardia and sinus tachycardia. Very clear? Yes? Alright, now let's see the examples. Okay, so let's see the first ECG recording in hand. Well, here you can see in the ECG strip in front of you, okay, this is actually a classical ECG of a normal sinus rhythm. Okay, normal sinus rhythm. So every P wave is followed by a normal QRS, and when you take into account the heart rate, you can see the number of large squares is 1, 2, 3 and 4 large squares. So 300 divided by 4, approximately the heart rate is 75 per minute. Okay. So this is a classical example of a normal sinus rhythm. Clear? Okay. Alright. So what are the features of a normal sinus rhythm in ECG? Let's just quickly recap. One, it is a regular rhythm at a rate of 60 to 100 beats per minute, and each QRS complex is preceded by a normal P wave, okay, and a normal P wave axis is there, which means you will have an upright P wave in leads 1 and 2 and an inverted P wave in lead AVR. The PR interval is remaining constant and it's a normal size QRS complex because the QRS complex is not wide here, okay, so it is a normal size, so it will be less than 100 millisecond unless there is a coexistent interventricular conduction delay, otherwise QRS will be normal. So these are the characteristics of a normal sinus rhythm. Clear? Okay. Now moving on, the next subdivision of the sinus rhythm is sinus bradycardia. Okay, is a sinus bradycardia. So remember, in sinus bradycardia also, here definitely the SA node is acting as the pacemaker. So every P is followed by QRS, and what you can see here is that the rate of depolarization, when you take into account the heart rate, let's just calculate number of large squares 1, 2, 3, 4, 5 and approximately 6. So you will have the heart rate to be 300 divided by 6, approximately 50 per minute. Okay, it is 50 per minute, not approximately, but so it's 50 per minute. So here it is less than 60 per minute, so this is falling into the group of sinus bradycardia. Clear? Alright, fine. Now the next rhythm, sub-rhythm is a sinus tachycardia. Sinus tachycardia. So here also every P wave and then a QRS, but you see here the rate, it's just 2 large squares. So again 150 per minute is the heart rate. Okay, so this is a sinus tachycardia. Okay, all right. So having learned regarding the 3 subtypes of sinus rhythms, let's also know another term that is referred to as sinus arrhythmia. Okay, sinus arrhythmia. So what is this sinus arrhythmia means? See, in certain normal young as well as healthy individuals, you can have a respiratory variation in your heart rate. Okay, so when you look at the ECG during inspiration, okay, during inspiration there is a inhibition of vagus, and there is an increase in heart rate. Okay, whereas during expiration there is a stimulation of vagus and there is a decrease in heart rate. Okay, so there can be a phasic variation. Okay, because that is what you see here. If you look at the RR interval, this is actually an individual who is otherwise young and healthy, but you can see that during respiratory phases there can be a variation in the heart rate, okay, between inspiration and expiration. So such sort of an arrhythmia is actually called a sinus arrhythmia. Okay, remember, this is not any disease process. This can occur in young healthy individuals. Okay, all right, so that is clear. So after the sinus rhythm, next we are going to discuss regarding junctional rhythm. Okay, junctional rhythm. Now what is this junctional rhythm? Well, when you take the conducting system of the heart, see what is that lies at the junction of the atria and ventricles. You can say that it's almost the AV node that is at the junction point. So junctional rhythm is the rhythm where the AV node is acting as the pacemaker. Okay, so in junctional rhythm, first point that you have got to know is that the AV node is the pacemaker. So when AV node is the pacemaker, let's try to see what will happen to the ECG. Well, when the AV node is the pacemaker, again going back to the figure, so for the depolarization from the AV node, to the atrial side, the impulses goes, and similarly, to the ventricular side also there will be a propagation of impulse. So often what happens is, sometimes you can have the atrial depolarization and ventricular depolarization occurring simultaneously. So since the QRS complex is the larger complex compared to the P wave, often the P wave will be submerged inside the QRS complex. Why? Because both the depolarizations are happening together. So you will have a QRS complex and the P will be mostly submerged inside the QRS complex. However, you can also have a scenario where the P occurs slightly before the QRS or slightly after the QRS. Well, in such scenarios, since the depolarization of the atria occurs in a retrograde direction, what sort of P waves are you expecting? You are expecting retrograde P waves. Okay, that is inverted P waves. Okay, inverted P waves. So AV node is acting as the pacemaker. So in the ECG, so what will happen? Either P is absent, but remember, I'll put this in inverted comma because P is absent only because it is submerged within the QRS, or you can have what? You can have inverted P waves. You can have inverted P waves. So that is what happens in case of junctional rhythm. Okay. Now, just like we discussed in sinus rhythm, the junctional rhythm also can be subdivided into three. Okay. And what are the subdivisions? Number one is a junctional escape rhythm. Okay. It's a junctional escape rhythm. Okay. Number two is an accelerated junctional rhythm, and number three is junctional tachycardia. Okay, is a junctional tachycardia. Now, what is the basis of such a classification? This is also based on the rate of depolarization. In case of junctional escape rhythm, the rate of depolarization will be around 40 to 60 per minute. In accelerated junctional rhythm, the rate will be ranging from 60 to 100 per minute, and junctional tachycardia will be more than 100 per minute. Okay, so junctional escape rhythm, accelerated junctional rhythm, and junctional tachycardia. Clear? Okay. Now moving on, just let me show you the ECGs. So this is a classical junctional escape rhythm, because as you can see here, the inverted P wave they have highlighted. Okay, so there are the P waves occurring here, but they are actually retrograde, okay, or inverted P waves that you are seeing. But again, the QRS morphology is normal, because see, when the AV node is acting as pacemaker, the impulse goes down through the conducting system, the two bundle branches. So the depolarization of the ventricles are happening together. So the QRS shape in case of a junctional rhythm is also normal, just like in case of sinus rhythm. So this is a junctional escape rhythm. Okay, this is a junctional escape rhythm. Clear? Okay. All right. Now the ECG features of junctional escape rhythm, the rate at around 40 to 60 beats per minute, narrow QRS or normal QRS, and there is no relationship between the QRS complexes and any preceding atrial activity. Okay. Because see, it is not that the SA node is acting as pacemaker here, it is the AV node that is acting as the pacemaker. So whatsoever, there won't be any definite relation between the preceding atrial activity, whether it be P waves or flutter waves or fibrillatory waves. The reason being AV node is acting as the pacemaker. Okay, all right. Now the second type of junctional rhythm is the accelerated junctional rhythm. Okay, accelerated junctional rhythm. Now what is this accelerated junctional rhythm? Now when you talk of, say, the junctional escape rhythm, it often is because the SA node is having some sinus arrest. Okay, that is the reason why someone will have a, say, a junctional escape rhythm. But when it comes to the accelerated junctional rhythm as well as junctional tachycardia, so those two, okay, the accelerated junctional rhythm as well as junctional tachycardia, it actually occurs because of, it's not just primarily because of a sinus disease, it is because of increased automaticity of AV node. Because if it was a normal automaticity of AV node, it would not have produced a rate like this. Okay, so there is increased automaticity of AV node that occurs in these two conditions, whereas in case of junctional escape rhythm, it's often because of any sinus arrest. Okay, where the SA node is not functioning as the pacemaker and the AV node takes over. Okay, all right. So this one is a accelerated junctional rhythm. Okay, accelerated junctional rhythm. So where the rate should be between 60 to 100. So you can see it's 1, 2, 3, almost, in the range of, just under 100. So because of which, and you can also see the inverted P waves. Okay, very definitely you can see. Again, an indication of the retrograde conduction. So this is accelerated junctional rhythm. Now, accelerated junctional rhythm, what are the ECG features? It is a narrow complex rhythm. Okay, remember I told you about all these sinus rhythm as well as junctional rhythm. They are having normal shape of the QRS. Okay, so narrow complex rhythm with a QRS duration less than 120 milliseconds. Okay. Unless there is some pre-existing bundle branch block or some aberrant conduction problems, okay, and the ventricular rate is between 60 to 100 that we have seen so far. Retrograde P waves may be present, can appear before, during or after the QRS complex, and when it occurs during the QRS complex, it is often submerged inside the QRS complex. Okay. And the retrograde P waves, they are usually inverted in the inferior leads 2-3 AVF and upright in case of AVR and lead V1. Okay, and AV dissociation may be present sometimes with the ventricular rate usually greater than the atrial rate. Okay, so these are the ECG features of accelerated junctional rhythm. Clear? Okay, and what are the causes of accelerated junctional rhythm? It can be because of digoxin toxicity. Remember, this is not specific for any condition but can occur as a part of digoxin toxicity. Beta agonists like isoprenaline and adrenaline, myocardial ischemia, myocarditis, cardiac surgery, these are the causes of accelerated junctional rhythm. Okay, clear. Now this last ECG, now you tell me what is this likely to be. Well, you are not, it's again a regular rhythm, but you are not able to appreciate the P waves, but it is very regular, so it's not any atrial fibrillation. So probably, the P waves would have been submerged inside the QRS. Now, what do you make out on the heart rate? See, definitely the heart rate, is slightly above, 100 here. Okay, so because of which you can actually call this a junctional tachycardia. Okay, junctional tachycardia, because it is between the two R waves. You can see it is just above 2 large squares. Okay, so definitely the heart rate is above 100. Okay, so this is a junctional tachycardia. Clear? Okay, So I hope you are clear with the junctional rhythms now. Now sinus rhythm is over, junctional rhythm is over. The next rhythm that you are going to learn is idioventricular rhythm. Okay, is idioventricular rhythm. So what is this idioventricular rhythm? So idioventricular rhythm, see the pacemaker, okay, we have seen regarding sinus rhythm where SA node is acting as pacemaker, the junctional rhythm, AV node is acting as pacemaker. In case of idioventricular rhythm, see the pacemaker is somewhere below the bundle of His. So the portion of the conducting system below the bundle of His anywhere, that is when you get idioventricular rhythm. So the most important point that you have got to know is that the pacemaker is below bundle of His. Now when you look at the ECG of patients with idioventricular rhythm, see when the pacemaker is below bundle of His, okay, I am just taking your attention to this picture. So this is the bundle of His, is being marked, and below the bundle of His, when it comes to the bundle branches, see if one of the bundle branches is acting as the pacemaker, just suppose, which means the ventricular depolarization in both the ventricles are not going to occur simultaneously. Which means, won't you agree with me when I say that the QRS complex is going to be wide here? Because the right ventricular and left ventricular depolarization does not occur together. So the duration of QRS complex is likely to be wide. Okay. So the ECG, feature, one of the important striking feature of the ECG in case of idioventricular rhythm is the wide QRS. Okay, one of the most important features is the wide QRS. So let's just have a look at the ECG. Okay, and before that, let me just tell you that even in case of idioventricular rhythm, you can further subdivide this into three rhythms. One is idioventricular escape rhythm, idioventricular escape rhythm. Number two is that of accelerated idioventricular rhythm. Okay, and the final one is idioventricular tachycardia. So here also the basis for such a classification is based on the rate of depolarization. Well, in case of idioventricular escape rhythm, the heart rate comes to maximum of around 40 per minute. Accelerated idioventricular rhythm 40 to 100 per minute. Some books you might see 50 to 100 per minute. So roughly in that range. And idioventricular tachycardia means more than 100 per minute. Okay. So this is how you will subdivide the idioventricular rhythm. So when you take the idioventricular escape rhythm, I'll just show you an ECG. See, something that is very striking is the broad QRS. I told you wide, bizarre QRS complexes, because the ventricular depolarization is not happening in unison. So you'll be having wide, bizarre QRS complexes. And the rate also will be, very low. You see here the number of large squares separating the two RR is 1, 2, 3, 4, 5, 6, 7, 8. So you can see almost, 8 large squares between the two RR. So the rate actually will be significantly low in case of idioventricular rhythm. Again, a feature of the inherent automaticity of the, conducting system, the Purkinje fibers or the bundle branches like that. Okay. So that is called idioventricular escape rhythm. Okay, idioventricular escape rhythm. Okay, all right. Now, if the heart rate actually is more, I told you if the heart rate goes above 40 to 100 range, as in case of here, where you can see 1, 2, 3 and almost 4. Okay, not 4. But if you take it as 4, you see it somewhere around 75 per minute. So it is in that range of 40 to 100 per minute. And if somebody asks you, can this be a junctional tachycardia or junctional rhythm? Junctional rhythm will have a normal QRS. Here quite obviously the QRS is wide. So this is going to be a idioventricular rhythm. So this is going to be at a rate of, in the range of 40 to 100. So this is going to be a accelerated idioventricular rhythm. Accelerated idioventricular rhythm. Accelerated idioventricular rhythm, AIVR. Now, accelerated idioventricular rhythm, see the rhythm AIVR may be associated with certain other ECG findings like capture beat as well as fusion beat. Okay, it may be associated with other features like capture beats as well as fusion beats, may be an accompaniment of the accelerated idioventricular rhythm. Now, what is this capture beat, fusion beat? So, what I have shown as V, this is the normal idioventricular rhythm, the accelerated idioventricular rhythm. But in between you are seeing, capture beat as well as fusion beat. Capture beat means, see, remember normally in case of an idioventricular rhythm, the pacemaker is below the level of bundle of His, correct? So the SA node definitely is not acting as pacemaker, but sometimes, okay, sometimes this SA node regains transiently, okay, it regains its power of being a pacemaker. So transiently it captures, okay, the ventricular depolarization rate, okay, transiently it determines the ventricular depolarization rate. So this one is actually the one that is marked as C is a capture beat, where this SA node is temporarily, taking over the pacemaker and then suddenly, it goes off. But how did I understand, it is the SA node has taken over? Because you can see compared to the two previous beat, here the QRS complex is normal. So you have got a normal QRS complex. So that is what you call as the capture beat. Now what is a fusion beat means? Okay, in case of an idioventricular rhythm, you have the ventricular, the conducting system, the Purkinje fibers or maybe the bundle branches being the pacemaker. But sometimes there can be a fusion, okay, simultaneously an impulse from the supraventricular region as well as ventricular region. Together they are acting as pacemaker and together they are depolarizing. So that will actually result in a hybrid complex. Okay, that will result in a hybrid complex. So that is what is called a fusion beat, where you have impulse from the SA node as well as the the ventricular ectopic together merging into a hybrid complex. So hybrid complex will have features of the a mixture of the normal QRS versus that of the idioventricular rhythm. The QRS may not be as large as that of a idioventricular rhythm, but again not as small as the QRS of a normal depolarization. So it will be a mixture, it will be a hybrid complex. That is what is called as a fusion beat. So in AIVR you may get capture beats as well as fusion beats. That's clear. Okay. Alright. Now accelerated idioventricular rhythm. There are various causes for accelerated idioventricular rhythm, but the most important one that I want you to remember, the most common arrhythmia that is related to AIVR is during the reperfusion phase of acute myocardial infarction. See, when you have a patient being admitted with a ST elevation myocardial infarction and you are thrombolizing the patient, post thrombolysis as a marker of reperfusion, you might have certain arrhythmia which you might call as a reperfusion arrhythmia. Okay, reperfusion arrhythmia. Okay, so during the reperfusion phase you may get, it's not necessary that all cases of reperfusion have this arrhythmia, but you may get an accelerated idioventricular rhythm, which is the most common clinical setting where you get a AIVR. Then beta sympathomimetics like isoprenaline or adrenaline, drug toxicity especially digoxin, cocaine, volatile anesthetics like desflurane, certain electrolyte abnormalities, cardiomyopathies, congenital heart disease, myocarditis, and following a cardiac arrest, return of spontaneous circulation, you may have it. Athletic heart also you may have it. So AIVR is not a diagnostic of any particular condition, relatively non-specific, but taking into account the common clinical practice, it is more commonly associated with reperfusion, associated with myocardial infarction thrombolysis. Okay. All right. So that is also clear. Now this is just to show you another example of a patient who actually had a ST elevation myocardial infarction. He subsequently was thrombolized, and you can see accelerated idioventricular rhythm, AIVR. Okay, because in some textbook you will see this terminology as the signature arrhythmia of reperfusion. Okay, but again please understand that this is not a very specific arrhythmia for reperfusion. Okay, all right. Now we have learned regarding the idioventricular rhythm also. What have we learned? Sinus rhythm, junctional rhythm, idioventricular rhythm. Now there is another rhythm which you can call it as the Geminy rhythm. So what is this Geminy rhythm? See, when in the conducting system, sometimes you can have a ectopic generation of impulses. You can have ventricular ectopics. So you can have individuals where SA node is the pacemaker, but in between you are having some ventricular ectopics. And in the ECG, the representation might be that of PVC, premature ventricular complex. Okay, you might have PVC, premature ventricular complex. Okay, so what happens is you can have in one individual, even multifocal PVCs as well. So this is an ECG where, the individual has multifocal PVCs. So how did I identify that there are ectopic impulses from multiple sites? Because you see, this one which I mark as 1 and this one which I mark as 2, these QRS are actually having different morphologies. So when you have premature ventricular contraction from different sites, they can have different morphologies. Okay, so you can call it this condition to be having a multifocal, premature ventricular contractions. Okay, premature ventricular contractions, or you can call it even complexes as well. Now, one of the important features of a PVC is that, see, this is a normal QRS complex. This is also a normal. And then comes a premature contraction. So when you have this, the one which is marked as 2 that is coming, and this PVC will be followed by a compensatory pause. Okay, this PVC will be followed by a compensatory pause, and it is after a gap that the next QRS actually comes. So if you take into account, normally if this is RR between two R waves, what happens is that if there is an interspersed premature ventricular contraction, there will be a long compensatory pulse also. So that if you take the difference between the two RRs, normal RRs, that will be 2 times the initial RR interval. Okay, because of the compensatory pause. Because the next impulse has to come, because the other impulse is not going to get fired. So it will come only after the refractory period, and so it will be 2 RR between the 2 normal QRS complexes. Okay, very clear. Now, why am I talking of this multifocal PVCs now? Well, the issue here is sometimes these premature ventricular contractions can occur in a rhythmic manner. Because if you ask me, is this ECG strip suggestive of any rhythm? But the PVCs are not occurring in any rhythmic manner. But certain scenarios, they can occur in a rhythmic manner. And that is when you bring in this term Geminy rhythm. Geminy rhythm. Let me show you the next ECG. Here you can see this is a normal QRS. This is also a normal. But after every normal QRS, there is something abnormal here. Okay, something abnormal here. So that one is a PVC. You are not seeing any, P wave. It's just a, the ventricular ectopic that is actually showing as the PVC. So, but it is occurring in a definite rhythm. It's not any, occasional premature ventricular contraction. It is occurring in a rhythmic manner. So, if every second wave or every second complex is a PVC, if every second complex is a PVC, you will call it as a ventricular bigeminy. You will call it as a ventricular bigeminy. At the same time, if it is every third wave, okay, if the every third wave is a PVC, then you can call it ventricular trigeminy. Ventricular trigeminy. Just to again substantiate this, just look at this particular ECG. You see here, this is a PVC, okay. But if you look at the rhythm, it is actually happening every alternate, okay, every second beat is actually, if you look at the rhythm, okay, that is the rhythm strip, you can see this one, this one, this one, this one, okay. So every alternate is actually PVC, then you can call it, this one is going to be a ventricular bigeminy. If every second beat was there, okay, if every third beat was there, you could have called it trigeminy. Okay. So I hope this Geminy rhythm is also clear for you. So what have we learned so far? We have learned what determines the rhythm. We have learned what is a sinus rhythm and the subdivisions, the junctional rhythm and the subdivisions, the idioventricular rhythm and the subdivisions, and what is meant by a Geminy rhythm. Okay. So the next step in the interpretation of ECG is axis determination. Okay, so determination of axis. Okay, all right. Now, first of all, let's try to understand what is this term axis, and after that we'll move on to axis determination. Okay, now see this term axis. Okay, the term axis has certain other synonyms. You can call it by the name cardiac axis. Okay, cardiac axis, electrical axis. You can even cardiac electrical axis. Okay, so these are some of the synonyms. Now, to have a basic idea regarding axis, you have got to have a good understanding about the sequential steps of ventricular depolarization. Okay, so I'm going to take you to 4 images, that is from image A, B, C and D. Well, these 4 images are actually the 4 sequential steps of ventricular depolarization, that is step A, B, C and D. Now in each of these steps there is also a corresponding vector. Okay, so the vector means it is the net direction of depolarization. So in each of these you will have a vector, that is vector 1, vector 2, vector 3 and vector 4, each corresponding to the net depolarization in that particular step. Now also depicted in these images are the ECG deflections, okay, corresponding to the net vector. So you can see, in the lead 2, it is corresponding to the lead 2, you can see the ECG deflections as well. Okay. Now see, in the sequential steps, let's begin with step A. The first step in case of ventricular depolarization, okay, is actually the septal depolarization. It is the septal depolarization. Now the direction of septal depolarization is actually from left to right. Okay, direction of septal depolarization is from left to right, that is the interventricular septum is getting depolarized. So you can see all these small green waves, no? All these small green waves are the depolarization waves, and the red is the net direction of depolarization, that is vector 1. And you can see the deflection as well, in lead 2, the Q wave corresponding to the septal depolarization. Now moving to step B, well, in step B what happens is there is a paraseptal depolarization. What is it? You have a paraseptal depolarization. So again you can see all these small green waves, yes, all these small green waves showing the paraseptal depolarization. Now the net direction of depolarization is again the vector 2, okay, that is a net vector for depolarization corresponding to the step 2, and you can see the net direction there. Now in step C you can see the depolarization that is moving from endocardial to epicardial region. That is the net direction of depolarization. You can see it is vector 3, because you see there is a depolarization of the right ventricle and all these small waves depolarizing the left ventricle as well. But again, since the left ventricle is more bulky, you can see the net deflection is tilted towards the left ventricle. And finally you have the step D, where the vector is actually 4. So you can see the base of the heart already was depolarized in the previous step. Now the base is actually getting depolarized. Okay, so that is actually step 4. Now these are the sequential steps of ventricular depolarization. So corresponding to A, B, C, D steps, you have vector 1, 2, 3, 4. Now let's put all the vectors into a single figure, okay, into a single figure. So you can see here you have the vector 1, vector 2, vector 3 and vector 4. Now all these vectors combined should have an average vector or a mean vector. Now the mean vector of all these 4 vectors is the cardiac axis. Okay. So what is the cardiac axis? What is the cardiac axis? It is the average direction of depolarization, average direction of depolarization wave, okay, this average direction of depolarization wave, that is what is called a cardiac axis, okay, the average. You can even call it the mean electrical axis, mean electrical axis, okay. So you can see here, this is the green, the green arrow corresponding to the mean axis, mean electrical axis, which is quite obvious, okay. All right. So you have understood what is this cardiac axis, basically what it is you have understood. Now there are a few other points that you have got to understand. Let me just explain to you. Well, see, when you have this depolarization wave that is actually spreading in a downwards and to left direction, when you have such a depolarization wave, you please note that this depolarization wave is actually spreading from a 11 o'clock position to a 5 o'clock position, okay. That is the net direction of the depolarization wave. You can also say that the wave is actually traveling towards lead 2, although not exactly towards lead 2, but very close to lead 2, and you can say, in other words, it is moving away from lead AVR as well, okay. So you have a look at lead AVR and lead 2. You can see this average direction of depolarization wave is towards lead 2 and away from lead AVR, or in a 11 o'clock to 5 o'clock position, okay. All right, so that is very clear. Now let us have a look at the next figure. So the solid black line or black arrow is corresponding to the mean electrical axis, mean electrical axis. Now, since the mean electrical axis is traveling to, in the direction of lead 2, the lead 2 will have a net positive deflection. Okay, it will have a net positive deflection. Whereas since it is traveling away from lead AVR will have a net negative deflection. Will have a net negative deflection. Okay, so you see about the mean electrical axis. Net positive deflection, net negative deflection. Okay, that's also clear. And one more point I want to tell you is, you just see, when you talk about the axis, I have told you before also, with respect to the position of the heart, all these leads are like cameras, looking at from different angles. So you see the lead 1 is at 0 degree, lead 2 at 60 degree, you have the lead 3 at 120 degree, AVF 90 degree, AVL minus 30, AVR minus 150. So all these are actually cameras. Okay, all right. So moving to next figure. Now if you ask me, I am sure that you have understood what is a cardiac axis. Now putting it to mathematical terms, well, the normal cardiac axis will fall anywhere between minus 30 degree, okay, normal axis of the heart will fall anywhere between minus 30 degree to plus 90 degree. So in this pink area in the graph, anywhere it is falling the net axis, you call it normal axis. Okay, it's a range minus 30 to plus 90 degree. Okay, now about the abnormalities like RAD or right axis deviation, left axis deviation, extreme axis deviation, we'll come to that in a short while. For the time being, understand what is a normal axis. It is minus 30 to plus 90. Some books might give it as minus 30 to plus 110. But again, mostly it is 90 degree that is being followed as the normal cardiac axis. Okay, all right. Now, see, I have told you before that the lead 2 will have a net positive deflection, lead AVR will have a negative deflection. But I am showing you another figure just to substantiate one more point. See, lead 2 is having the positive deflection, I agree. But please understand that lead 1 as well as lead 3, they also will be having a positive deflection, because here also it is moving towards these leads, but it is moving more close towards lead 2, which is why the most prominent positive deflection, if you see, that will be with respect to lead 2 over and above lead 1 and 3. So lead 2 in a normal axis will be having the greatest height of the positive deflection compared to lead 1 and 3. But lead 1 and 3 also will be having a positive deflection. Okay, alright, so that is also clear. Now just have a look at the normal axis between minus 30 and 90. What is shown in yellow is the normal axis. Okay, alright. Now let me give you another scenario. Okay, another clinical scenario where suppose, okay, you have got a patient with right ventricular hypertrophy. Okay, the patient has got a right ventricular hypertrophy. So normal axis, it is downwards and to the left, because the left ventricle is exerting a stronger impact. But when there is a right ventricular hypertrophy, what can happen is that the right ventricle actually exerts a more stronger impact. So because of which the axis can shift from the normal range and it can shift rightwards and downwards, or in other words, the patient can have a right axis deviation. Okay, he can have a right axis deviation. So when there is a right axis deviation or the mean electrical axis shift towards right, you now tell me which is the lead that is going to have a prominent positive deflection. It is going to be the lead 3 that has a prominent positive deflection. Even lead 2 will also have a positive deflection. But remember, in normal axis, lead 2 had a more stronger positive deflection compared to lead 3. But here lead 3 has a better positive deflection. And lead 1 will have a negative deflection. Okay, This is called a right axis deviation. Clear? Alright. So right axis deviation means it is falling between plus 90 degree as well as 180 degree. Okay. So this portion which I am showing in red, this is the region of right axis deviation. So you have understood normal axis and right axis. Okay. Alright. So next let me tell you another scenario where say the patient has got a left ventricular hypertrophy. Okay. The patient has got a left ventricular hypertrophy. So when the patient has got a left ventricular hypertrophy, what happens is, again there would be a change in the net depolarization vector or the mean electrical axis. So previously the axis was in this direction, correct? But now what will happen is that the axis will again shift leftwards, and you will have a left axis deviation. You will have a left axis deviation. LAD, left axis deviation. Okay. So when you have a left axis deviation, the lead one will be positive, but again the magnitude of positivity might be again smaller because it is going away from, but even then lead 1 would have a positivity there, but lead 2 as well as lead 3 will have predominantly a negative deflection, okay, because it is moving away. Lead 1 will have slightly positive, okay, that is also clear, okay. So, but remember that in addition to left ventricular hypertrophy, we said right ventricular hypertrophy, right axis deviation. Well, left ventricular hypertrophy, left axis deviation, but the left axis deviation can also occur because of certain conduction abnormality. So, what conduction abnormality? That is what we are going to learn. Just have a look at that. Left axis deviation, minus 30 degree to minus 90 degree. Okay, remember minus 90 degree. That is LAD, left axis deviation. Okay, all right. Now just see, I'm going to talk about the conduction abnormality. Now the first figure I'm showing you is a normal conduction system where you see the AV node, bundle of His, right bundle branch, left bundle branch. It is having an anterior fascicle and posterior fascicle for this left bundle branch. And you are seeing the direction of depolarization wave spreading across the bundle branches as well. Okay, all right. Now just have a close look at the anterior fascicle as well as posterior fascicle. In a normal individual, the net axis will be in this direction, correct? We've already seen that normal conduction. But when there is a block in the left anterior fascicle, okay, so there is a block in the conduction pathway in the left anterior fascicle, then what happens is that the normal spread of depolarization does not occur through the anterior fascicle. So it has to travel through the posterior fascicle, and then from the base apex it has got to move towards the base. So again the axis can shift. In this case there can be a left axis deviation. Okay, so that is how in case of a left anterior fascicle block, okay, you can call it LAHB, left anterior hemiblock, that is the anterior fascicle is being blocked, there also you can get a left axis deviation. However, in case of a right bundle branch block, in that case the depolarization wave again does not shift much. It is again towards the region of left ventricle, so the axis does not shift much in a right bundle branch block. But in a left bundle branch block, what happens is when there is a left anterior hemiblock, there occurs a left axis deviation. But on the contrary, if there is a posterior fascicle that is being involved, then you get the opposite, you get the right axis deviation. Okay, so if it is an anterior fascicle, left axis deviation, posterior fascicle is involved, there is a right axis deviation. Okay, so in short, you can get a left axis deviation or right axis deviation depending upon which chamber of the heart hypertrophies or is under strain. Okay, that is how the axis actually is determined. Okay. The axis actually is varying depending upon the pathologic conditions. Okay, this is clear. Now we are moving on to determination of axis. Because we have understood axis, now we are moving on to determination of axis. So just look at all our cameras, lead 1 at 0, lead 2 at 60, 120, 90, minus 30, minus 150. Now to determine the axis, okay, we are going to determine the axis. There are different methods, okay, there are different methods for axis determination. So most of them, are good methods, but we'll just go for a simple method that is called the quadrant method. That is what I'm going to discuss. Quadrant method, the name of the method is quadrant method. Okay. There are other methods also like isoelectric lead method, multiple other methods are there. So we are going to discuss regarding quadrant method. So in quadrant method, the axis determination is mainly dependent upon lead 1 and lead AVF. That is the cameras at position 0 degree and plus 90 degree. Okay. So that is going to tell us about the axis. Okay. All right. Now, you see here, whenever you have a particular deflection in the ECG, you see here this is the height of the R wave, this is the depth of the S wave. When the R minus S is positive, okay, R minus S is positive, you say that there is a positive deflection, okay. When the R is equal to S, you can call it equiphasic. Whereas when the R minus S is negative, okay, you say that there is a negative deflection. Okay, negative deflection. Positive deflection, negative deflection and equiphasic deflections. Okay, alright. So now I will teach you how to calculate the axis based on the quadrant method. Okay, I will be teaching you with examples so that it is very clear. So we are going to go for the quadrant method. Alright, so in the quadrant method, first of all you have just got to plot the graph. Okay, so you know that lead 1 is here, lead AVF is here. So lead 1 positive is here, negative is here, lead AVF positive is here, negative is here. Okay, and in the quadrant method, the plotting is based on lead 1 and lead AVF. There are other methods also where the other leads are also taken into consideration. But always remember it is the limb leads that are being taken into consideration for the axis determination, never the precordial leads. So lead 1 and lead AVF. So first look at the scenario, the first ECG that we have. So first you have got to look at lead 1, okay, lead 1. You have got to look at the R minus S in lead 1. You tell me, you look at the height of R wave and the depth of S wave. Actually you can go for the calculation based on the number of boxes. But again, certain scenarios visual impression is enough, especially for entrance purpose, you don't have much time to calculate. But one thing is quite obvious, here the R minus S in lead 1 is actually a net positive. Whereas when it comes to lead AVF, here the R minus S is again a positive deflection. Okay, is again positive. So lead 1 is also positive, AVF is also positive. Okay, which means it will fall in this particular quadrant. Okay, it will fall in this particular quadrant, that is between 0 degree and plus 90 degree, that is the axis. Or you can say that this example is that of a normal axis. Okay, it is of a normal axis. Okay, let's move to the next example. Alright, now be with me, you also calculate. So let's plot here 1 AVF 0 degree plus 90 degree, positive, negative, positive, negative. Okay, Now look at lead 1 here. What do you think? The R minus S is very obviously, this one is going to be a negative. Okay. And coming to AVF, again the R minus S is going to be positive deflection. So lead 1, it's positive, it's negative, whereas in case of lead AVF, this one is a positive deflection. So which means the axis would be in this direction. Okay, in this direction. And what will you call it? You will call it a right axis deviation. Okay, which means the axis is between plus 90 degree and 180 degree. That is called the right axis deviation. Okay, that's also clear. Now coming to the next example. See, this one is also an interesting one. Let's plot this. This is actually a ECG of a ventricular tachycardia. 1 AVF 0, 90 degree, plus 90 degree, positive, negative, positive, negative. Now look at lead 1 here. So lead 1, this is the R wave, okay, and this is the S wave. And AVF also, you can see this is the R wave and this one is the S wave. So lead 1 R minus S, definitely negative deflection. Lead AVF also, you can see R minus S is again definitely a negative deflection. So negative in lead 1 and negative in lead AVF, which means the net vector will actually fall in this quadrant. Okay, that is between this minus 90 degree and 180 degree. Okay, so that axis is called an extreme axis deviation. This is called a extreme axis. So it goes to the northwest axis. This is the extreme axis deviation, and this mostly is seen with ventricular tachycardia. So normal axis, both are positive. R minus S is positive in both lead 1 and AVF. Extreme axis, both are negative. Okay, that's clear. So that is about extreme axis. So it's very important to identify the axis of the ECG. Remember, there are multiple methods. We have gone for the quadrant method. This is actually very simple, but often what happens in the exam is sometimes you might be a bit anxious and you might get this wrong. So just practice with simple examples so that you don't get this basic point wrong in your exams. Okay. The next step in the interpretation of ECG is the analysis of the P wave. Okay, analysis of P wave. So P wave, as we know, is the first positive deflection in the ECG. So this is the P wave. So this P wave is actually corresponding to atrial depolarization. It is corresponding to atrial depolarization. Okay. Now let's learn more regarding the morphology of the P wave, and subsequently that will help us analyze P wave. Okay. So regarding the normal morphology of P wave. Okay. So I'm going to teach you the normal morphology of P wave. Normal morphology. So P wave normal morphology, see, it will have a smooth dome shaped configuration. Okay, it will have a smooth dome shaped configuration, and the normal P wave duration will be less than 120 milliseconds, that is less than 3 small squares. Okay, less than 3 small squares will be the duration. Whereas the amplitude of the normal P wave will be less than 2.5 millimeter. Okay. So the normal morphology, smooth dome shape, duration less than 120, amplitude less than 2.5 millimeter. Now you see, atrial depolarization, correspondingly you have P wave. But just think, you have got a right atria as well as a left atria. So when you say atrial depolarization, it should be the summation of depolarization of the right atria as well as left atria. So though I showed it as a smooth dome-shaped, wave, in actual sense, you have initial right atrial depolarization and a subsequent left atrial depolarization. Now, why first right atrial depolarization and then left atrial depolarization? Why is it so? Because the SA node is normally located inside the right atrium. So, who will depolarize first? The right atrium. So, then subsequently the left atrium will depolarize. So, you have got a right atrial depolarization followed by a left atrial depolarization. But when it comes to the ECG, you will have a summated wave which is having a smooth dome-shaped configuration. Okay, that is going to be your P wave, which is right atrial depolarization plus left atrial depolarization. It's the summation. Now you see this figure also, the P wave, the right atrium in brown and left atrium in violet. So you can see the initial part corresponding to right atrium and the latter part corresponding to the left atrium. In fact, if you divide the P wave into three parts, the first 1/3 of the P wave will be corresponding to the right atrial depolarization. The last 1/3 of the P wave will be corresponding to left atrial depolarization, whereas the middle 1/3, in the middle 1/3 you will have both the atria depolarizing, that is the right atria and the left atria depolarizing. So that is how the normal P wave morphology looks like. Okay, so I hope the normal P wave morphology is clear for you. All right, okay. Now when you have a look at the various ECG leads and the P wave, well, something that is quite obvious is in most of the leads, okay, the P wave will be a positive wave. Okay, P wave will be a positive wave when you take lead 1, 2, 3, AVL, AVF, V2, V3, V4, V5, V6, everywhere the P wave is actually positive. But in case of lead AVR, the P wave is actually negative. So you will have a negative, you can see here, you have a negative P wave in case of lead AVR. And in case of lead V1, you will have a biphasic P wave. Now what is this biphasic P wave? I'll just show you. See, lead V1, you see the P wave will have a initial right atrial depolarization, which is a positive deflection, and then a subsequent left atrial depolarization, which is a negative deflection. So it will have a biphasic nature, okay, in case of lead V1. That's clear. Now let's move on to the abnormalities. Okay, now moving on to the abnormalities, suppose you want to analyze P wave. Okay, let's put the heading as analysis of P wave. First point you have got to know is the best lead. Okay, the best lead to assess P wave is lead 2 as well as lead V1. Lead 2 as well as lead V1. These are the best leads to assess the P wave. Okay, alright. Now, when you want to analyze P wave, there are two questions that you should answer to yourself. Number one, is the P wave present? Okay, is the P wave present? So normally if the SA node is the pacemaker, you will definitely get a P wave corresponding to atrial depolarization. But what if the pacemaker is, say, the ventricles? You might not be able to see the P waves. Also, suppose in conditions like atrial fibrillation, where you have the fibrillary waves and a definite P wave might not be demonstrable, the P wave may be absent. So the first question in the analysis of P wave, is the P wave present? Now second is, if the P wave is present, then the next question you have got to answer is, what is the morphology of P wave? What is the morphology of P wave? So P wave morphology, is it normal or is it abnormal? Okay. Now let's see some of the abnormal morphologies. Okay, let's see some of the abnormal morphologies. So the first abnormal morphology I want to teach you is with respect to left atrial enlargement. So maybe a condition like mitral stenosis where you have left atrial enlargement. Remember, left ventricle commonly hypertrophies, whereas the atrium commonly enlarges. So in case of left atrial enlargement, when the atria is larger, it's common sense that atria will take more time for depolarization. So the normal P wave, which will have a smooth rounded configuration, dome shaped configuration, that would be replaced by a P wave, which is having a longer duration. Longer duration means duration more than 120 milliseconds. And also you might have a notching in the P wave. Okay, you can see the notching in the P wave. So the duration will be increased, and there may also be a notching, you can see in this figure also. And this type of P wave where you have an increased duration along with notching may not be there in all scenarios, okay, but anyway the duration will be increased, and such a condition is referred to as P mitral. Okay, it is referred to as P mitral. Okay, so P mitral is actually corresponding to left atrial enlargement. Okay, P mitral corresponds to left atrial enlargement. Now just see this ECG again to make your concept clear. You can see the P mitral here. So definitely you will have P wave that is longer in duration, as well as the notching you can see in this case. But I told you all cases might not show the notching. So this is called P mitral. This is called P mitral. Okay, corresponding to left atrial enlargement. Clear? Okay. Now if you look lead V1 in case of the same condition, okay, lead V1. So in lead V1 I told you it is normally biphasic. So the initial part will be right atrial depolarization. So the abnormality or an enlargement would be expected in the second component, that is the negative deflection in case of the V1 lead. So that is where you are going to get enlargement in case of a P mitral. Okay, the left atrial enlargement. Okay, all right. So that is also clear. Now moving to the next scenario. Next scenario is where you have say a right atrial enlargement. So we saw P mitral with respect to left atrial enlargement. Now is the right atrial enlargement. So when you have a right atrial enlargement, in that case also right atrium would take more time to depolarize. So this is the normal morphology of the P wave. Now this will be replaced by a P wave that is having an increased amplitude. Okay, not the duration. There will be an increased amplitude. So the duration will more or less be same, but the amplitude will be higher. Okay, so you will have taller P waves. Okay, and this is actually called P pulmonale. Okay, this is referred to as P pulmonale. So rather than the rounded smooth dome shaped configuration, you are having a slightly taller P waves and slightly pointed P waves. Okay, so you are having pointed P waves. So that is what you get in P pulmonale corresponding to right atrial enlargement. Okay, all right. So even in this graph also you can see there is, in this increase in the height of the P wave you can demonstrate. And let's have a look at the ECG. You are seeing the pointed P waves which are tall. So which means that height would be, or the amplitude of P wave will be more than 2.5 millimeter in case of P pulmonale. So maybe associated with, say, chronic obstructive pulmonary disease, you can have this. So whenever subsequent, you can have the involvement of right side of the heart, there is right atrial enlargement, and then you can have P pulmonale. Clear? And P pulmonale in lead V1 also, this time you will have a prominence in the initial positive deflection part of the P wave in lead V1. Okay, that is what is seen in case of P pulmonale. So the interesting thing is that if you want to see both the components of atrial depolarization separately, you would prefer a lead V1, okay, where you can see the right atrial depolarization followed by the left atrial depolarization. Okay, all right. So just to sum up what we have learned, okay, the normal appearance of the P wave in lead 2 as well as lead V1, we saw that these are the best leads for appreciation. Right atrial enlargement, you will get P pulmonale, okay, P pulmonale, whereas left atrial enlargement, you will get P mitral. You can also go for the lead V1 to separately appreciate, the individual components of the P wave. And in some cases, you can have a right atrial enlargement plus left atrial enlargement in the same individual as well. Okay. So these are the abnormalities, especially that you should take care when you are analyzing the P wave. Okay. The next step in ECG interpretation is the analysis of the PR interval. Okay. All right. So first let's try to see what is this PR interval. Well, the PR interval is the interval that extends from the beginning of P wave. So when I say beginning of P wave means beginning of atrial depolarization till the beginning of QRS complex. Okay, beginning of QRS complex. And when I say beginning of QRS complex, it means beginning of ventricular depolarization. So PR interval is the time or the interval between the beginning of atrial depolarization to the beginning of ventricular depolarization. Okay. So see this term QRS complex, that is the PR interval from beginning of P to beginning of QRS. Now that QRS is independent of whether the QRS complex starts with a Q wave or a R wave, which means there can be a scenario in which the Q wave is not there, then it actually means the beginning of the R wave. Okay, so this QRS complex independent of whether it starts with the Q wave or the R wave. That is clear. Now the normal PR interval, okay, the normal duration of the PR interval is 120 to 200 milliseconds. Okay, normal value is 120 to 200 milliseconds, which is equivalent to 3 to 5 small squares. Which is equivalent to 3 to 5 small squares. So that is the normal duration of the PR interval. Clear? Now having seen what is PR interval, let us now move on to the significance of PR interval. So PR interval is actually corresponding to the atrioventricular conduction time. Okay, that is equivalent to the atrioventricular conduction time. So when I say atrioventricular conduction time, it means, okay, what is this atrioventricular conduction time? It means the time for atrial depolarization plus the AV nodal conduction delay, that is the delay across the AV node plus the conduction across the his bundle Purkinje system. Okay, his bundle Purkinje system. So this total time, including atrial depolarization, AV nodal conduction delay and the conduction across the his bundle Purkinje system, because it is after the conduction that through the his bundle Purkinje system that the ventricular depolarization begins. Okay, so that is called the PR interval. Okay, I hope you have understood what PR interval signifies. Now coming to the abnormalities of the PR interval. Okay, coming to the abnormalities of PR interval. So there can be prolongation of the PR interval, because I told you the normal value is 120 to 200 milliseconds. So there can be a prolongation of the PR interval, or there can be a shortening of the PR interval, or you can have a scenario where the PR interval is very much varied, okay, or a varying PR interval. Okay. Now one basic point that you should know is that the PR interval is also dependent on the heart rate. Okay. So if you have an increase in the heart rate, okay, an increase in the heart rate, what happens is the PR interval shortens. Okay. Whereas if there is a decrease in the heart rate, there can be a PR interval lengthening. Okay. So remember, this is actually within the limits of 120 to 200 milliseconds normally. Okay, that is a variation with heart rate. Okay, based on whether the in tachycardia or the when the pulse rate is on the lower side. So that is very, very clear. Now moving on to the abnormalities. First, let us take into account the PR interval prolongation. Now when does PR interval get prolonged? Now remember, out of the three components that I mentioned of the PR interval, this one, that is your AV nodal conduction delay, is very, very important, because if due to some chance there is a further delay in the conduction of across the AV node, then what will happen to the PR interval? It will get prolonged. So a prolonged PR interval, okay, we are just moving on to a scenario where an individual has a prolonged PR interval. So prolonged PR interval means it actually is above 200 milliseconds. Okay, 200 milliseconds. This is more than 5 small squares. So in some definitions they include more than 220 milliseconds. Okay, but that's okay. So this is prolonged PR interval. So a prolonged PR interval, well above 200 milliseconds, that can occur in a first degree heart block. Okay, that can occur in a first degree heart block. First degree heart block. Now remember, if you have some drug, okay, that acts on the AV node, so that the further conduction across the AV node is actually delayed, that can also lead on to a prolonged PR interval. So when you consider drugs like, say, digoxin, okay, digoxin, or beta blockers, or calcium channel blockers like verapamil and diltiazem, these all can lead to prolongation of PR interval. Okay, an increase in the PR interval. Okay, now if you look at this ECG that is shown, okay, so it is quite obvious. Look at the PR interval here. Okay, so this is the PR interval from the beginning of P to the beginning of QRS complex. So you can see it is definitely more than 5 small squares. So this is a prolonged PR interval. Okay, very, very important, that occurs in a first degree heart block. Okay, so that is quite clear, prolonged PR interval. Now we are moving on to the next scenario, where an individual can have a shortened PR interval. Okay, where the individual can have a shortened PR interval. Shortened PR interval. See, a short PR interval can occur in various scenarios. So one scenario will be that of a junctional rhythm, okay, an AV nodal junctional rhythm, where the impulse actually originates in the AV node, and from the AV node the impulse actually propagates. So the impulse from the AV node will go on to the ventricular side and it will go on to the atrial side retrospectively. So what will happen is that the impulse to the ventricles is moving in the normal direction, but the atria is getting activated in a retrograde manner. So what can happen is that there can be P waves, but the P waves will be inverted. Okay, the P waves in case of a junctional rhythm will be inverted. So just let me show you the ECG of a junctional rhythm. So junctional rhythm, you will have inverted P waves because of the retrograde conduction of impulse from the AV node to the atria. And this retrograde, conduction, the inverted P waves, these inverted P waves can occur either before or during or just after the QRS complex. Okay, so it can occur before, during or just after. If it occurs during the QRS complex, it will be submerged inside the QRS and you will not be able to visualize the P wave. Okay, so in this rhythm that you are seeing here, rhythm being shown here, you can see this is the inverted P wave. Okay, this is the inverted P wave that occurs just before the QRS complex. Okay, but you can see, it is less than 3 small squares, almost, in the tune of 2 small squares. So that is short PR interval. Okay, that one of the causes of a short PR interval is a junctional rhythm, where, the impulse can actually originate, or the AV node actually acts as the pacemaker. Okay, so junctional rhythm I have discussed separately. Okay, now shortened PR interval, one cause is junctional rhythm. The next cause of the shortened PR interval is pre-excitation syndromes. Pre-excitation syndromes. And in the pre-excitation syndromes, you have got to think of 2 syndromes mainly. One is the Wolff-Parkinson-White syndrome. Wolff-Parkinson-White syndrome. And the Lown-Ganong-Levine syndrome. Okay, these are 2 pre-excitation syndromes. This is very, very important. Okay, so let me just show you regarding the first one, the first pre-excitation syndrome, that is WPW syndrome, Wolff-Parkinson-White syndrome. See, in case of WPW syndrome, I told you this is a pre-excitation. So pre-excitation means the ventricles are getting activated in a premature manner. So let's see what that is. Listen, you have got 2 figures, 1 and 2. One is corresponding to the normal AV transmission. So you know that the impulse from the SA node comes to the AV node, bundle of S, then the bundle branches, the Purkinje system. That's the normal conduction. But in case of WPW syndrome, what happens is that there is a bypass tract. Okay, there is a bypass tract between the atrial myocardium and the ventricular myocardium, and this bypass tract is referred to as the bundle of Kent. Bundle of Kent. It is called a bypass tract because it bypasses the AV node. Bypasses the AV node. Let me be more clear on that. See, as you can see, the arrow that is shown in pink here, okay, corresponding to the pre-excitation, which means bypassing the normal AV node that is normally here. So bypassing this AV node, there is the impulse actually comes directly to the ventricles, ventricular myocardium. So there is a premature activation of the ventricular myocardium by this bypass tract. Okay, premature activation or a pre-excitation. What is that term? Pre-excitation. So there is a pre-excitation. Now when there is a pre-excitation, definitely what will happen to the PR interval, because normally you know that there is a AV nodal conduction delay. So here the AV node is being bypassed. So what will happen to the PR interval? It will be short. So that is one obvious fact, that there will be a short PR interval. Short PR interval. Now because of this pre-excitation, okay, ventricular myocardium getting activated prematurely, what will happen is that, let me just show you the ECG. So here you can see this is the P wave, okay, P wave. Now then what happens is that, what I am going to mark in green now, you will see a slurred upstroke, okay. There will be a slurred upstroke that is shown in the green color, a slurred upstroke, and this slurred upstroke is corresponding to the pre-excitation, okay. And this slurred upstroke that you can see on the ECG is referred to as a delta wave, okay, is referred to as a delta wave. So slurred upstroke is also referred to as the delta wave, okay, slurred upstroke, delta wave, okay, which is very, very important. Now the next point about the WPW syndrome is that the individual will be having wide QRS complex, okay, wide QRS complex. Now let me ask you one thing before that. You tell me, in individuals with WPW syndrome, will you normally be having a Q wave here? Will you normally be having a Q wave? Just think about it and let me know. See, what happens is there is a bypass, correct? No? The bundle of Kent is acting as the bypass. So, see, the next step that ideally should happen in the QRS complex is the septal depolarization that leads on to the Q wave. But here what happens is that the impulse is actually directly coming to the ventricular myocardium. So the initial step is not the septal depolarization, and very, very importantly, there will not be a Q wave, okay. There is no Q wave, okay, there is no Q wave. So you can see here, there is a P wave, okay, there is a P wave, there is a short PR interval, then there happens a slurred upstroke, okay, slurred initial upstroke, that is called the delta wave. But after the delta wave, you can see it actually takes off normally, okay, the normal steep nature. But the initial one is having a slurred upstroke, okay, which is called the delta wave. This is commonly asked in exams, okay, simple question regarding delta wave. So there is usually no Q wave, that is also very, very clear. Now the next point I told you is about the wide QRS complex. Now why is there a wide QRS complex? Now this is very interesting. See, impulse is actually passing through the bypass tract to the ventricular myocardium. You must remember that the conduction across the cardiac myocytes, because now the impulse has come to the ventricular myocardium and further conduction is through the cardiac myocytes. So the conduction across the cardiac myocytes will be at a slower pace compared to the normal conduction across the His bundle Purkinje system. So normally the impulse should have gone from the AV node to the His bundle Purkinje system. Well, it is true that the impulse has arrived early. Okay, there is a premature arrival of the impulse to the ventricular side, but further propagation is delayed because it is not going through the fast conducting His bundle Purkinje system, and because of that, the duration of ventricular depolarization will be prolonged and there will be a wide QRS complex. Okay, there will be a wide QRS complex. So that also is quite obvious here. Okay, the QRS complex is wide QRS complex. Okay, so these are the ECG features in case of the first pre-excitation syndrome, that is the WPW syndrome. Okay, and this is often actually asked in your exams, WPW syndrome. All right, now moving forward, the next type of pre-excitation syndrome is referred to as the Lown-Ganong-Levine syndrome. Okay, Lown-Ganong-Levine syndrome. Let me try to explain it for you. LGL syndrome. Lown-Ganong-Levine syndrome, LGL syndrome. Okay, so LGL syndrome means this is also pre-excitation syndrome. So which means here also you will have a bypass tract. Okay, and that bypass tract, remember about the bundle of Kent in case of WPW, this is actually called the James pathway. Okay, or the James fibers or the James pathway. Now this is acting as the bypass tract. Okay, this is acting as the bypass tract. But remember, this bypasses the AV node just like the WPW syndrome. But remember, in case of WPW, the bypass actually was to the ventricular myocardium. But here is the importance that the bypass here is only just bypasses the AV node. The impulse then actually comes to the His bundle's Purkinje system itself. That is the only difference is that it bypasses the AV node, but once it bypasses the AV node, further propagation, okay, the further propagation is through the His bundle Purkinje system. His bundle Purkinje system. Now this is very, very important. Let's have a look at the ECG of a patient with LGL syndrome. So the first point, like WPW syndrome, this individual also has a short PR interval, that is less than 3 small squares. So short PR interval is there, and you are not going to have a delta wave in comparison to the WPW. There is no slurred upstroke, so there is no delta wave. The next important point, and what about the the Q wave? The Q wave can be present. Okay, so Q wave is present. So Q wave is present. Why the Q wave is present? Because see, remember the impulse actually just bypasses the AV node. Now it comes to the His bundle system. So the septal depolarization would take place normally, and there will be a Q wave. Okay, that is also clear. And very, very importantly, you will have a normal duration of QRS complex in case of LGL syndrome. In case of LGL syndrome, you will have a normal duration of QRS complex. Now, why is it so? It's very simple. Because in case of WPW syndrome, you had a slower conduction through the cardiac myocytes, because of which the ventricular depolarization was prolonged. But here what happens is that the further propagation of the impulse occurs through the His bundle Purkinje system, because of which the QRS complex will be normal. Okay, normal duration of the QRS complex. So you can see here there is a short PR interval less than 3 small squares, but the QRS is normal. So okay, so these two are important. So shortened PR interval, junctional rhythm, pre-excitation syndromes. Okay, very, very important. All right, so the next point is that, and even when you talk of drugs like atropine, okay, drugs like atropine can also shorten the PR interval. Okay, can also shorten the PR interval, because actually it is facilitating the conduction through the AV node, which is why it shortens the PR interval. So remember we talked about abnormalities of PR interval. That is, we talked about the long PR interval, short PR interval, and what about conditions with varying PR interval? Okay, conditions with varying PR interval. So one classical example is that of a second degree AV block, that is Mobitz type 1 AV block. So what happens in case of a second degree AV block, that is Mobitz type 1? That initial PR interval, okay, it might appear normal, but subsequently what happens is that there is a progressive increase in the PR interval, and subsequently for this P, there is no QRS. Okay, there is no QRS. So you see, this is the PR interval, progressive prolongation, okay, prolongation, and then you can see for this P, there is no QRS. So what happens is that in case of the Wenckebach phenomenon, as it is called, okay, there is a gradual prolongation of the PR interval. There is a gradual prolongation of PR interval, or you can say there is a progressive prolongation of PR interval. Subsequently, what happens? There is a missed beat. Okay, so this is what is called the Wenckebach phenomenon. Okay, so varying PR interval can be seen in such scenarios. Okay, so just summing up about the PR interval, you should know what is the PR interval, what does it signify, and what are the abnormalities of the PR interval. Okay, the next step in ECG interpretation is the analysis of the QRS complex. Okay, analysis of QRS complex. Alright, so QRS complex corresponds to what? You tell me. Simple, it corresponds to ventricular depolarization. It corresponds to ventricular depolarization. Okay. Alright, so that is again very clear. You must understand one point, that the ventricular depolarization is predominantly dependent on the conduction across the bundle branches. Okay, so if I just take you to the image of the conducting system of heart, you have the SA node here, the AV node, the bundle of His, the left and right bundle branches, and the left bundle branch having a posterior fascicle as well as an anterior fascicle. So it is quite clear that the conduction across the ventricles, the intraventricular conduction, is dependent on the bundle branches. And when you say QRS complex, it corresponds to ventricular depolarization. That means the summation of the depolarization of left ventricle as well as the right ventricle, that is what is your QRS complex. Okay, very clear. Alright, now when you go into the analysis of the QRS complex, there are two questions that you should answer to yourself. What are those two questions? Number one, what is the relation of QRS complex to the P wave? And question number two is, what is the morphology of the QRS complex? Maybe you can even say what is the morphology and duration of the QRS complex. Coming to question 1. Now question 1 actually has two sub-questions. Okay, the relationship between QRS and P wave, there are two sub-questions. And what are these two sub-questions? The first sub-question is each P wave followed by QRS complex? Is each P wave followed by QRS complex? That is sub-question 1. Okay. Sub-question 2 is each QRS complex preceded by P wave? Now, sub-questions, both of them, do they look the same? Well, they are not same. They are two different questions. I'll try to explain that with examples. Let's take the first sub-question. Is each P wave followed by QRS complex? Now, you look at this particular ECG. This is an abnormal ECG. So, what is peculiar about the relationship between P and QRS in this ECG? You see here, there is a P wave, but following that there is no QRS complex. After some time there is a P wave, a QRS complex, then again a P wave, a QRS complex, then again a P wave, QRS complex, then the next P wave, there is no subsequent QRS complex. But again comes a P wave, QRS, P wave and QRS. So what you are able to see here is that at two places in this particular ECG strip, the P wave was not followed by a QRS. Okay. So you tell me what is the ECG diagnosis here? Well, the ECG diagnosis here is that of a second degree AV block, Mobitz type 2, okay, Mobitz type 2. Well, in detail about the AV blocks has been discussed in separate module. So here what actually happens is there is a AV nodal block, okay, because this AV node is a very important, gate pass between, the impulse transmission from the SA node to the bundle branches. So when there is a AV nodal block, definitely the impulse won't be transmitted across, and you see here the P wave was not followed by a QRS. So that is the first sub question you have got to answer, whether each P wave is followed by QRS complex. Now the second sub question is each QRS complex preceded by P wave? Now what's the relevance of that question? And again, let me show you another ECG example. So look at this example. Another ECG strip is given. Here also you have an abnormality. And what is the abnormality? So initial part you can see P wave, QRS, because if you answer the first sub question, is each P wave followed by QRS? Let's try answering that sub question. Is each P wave followed by QRS? P, QRS, P, QRS. Then there is no subsequent P. Here there is a P followed by QRS, P, QRS, P, QRS. Again P, QRS, P, QRS. Okay. So if you ask me this question, is each P wave followed by QRS complex here? My answer is yes. But you answer the second sub question, whether all the QRS complexes are preceded by P wave. You see that the third QRS complex here, which I am just highlighting in red, you see this wide QRS complex, don't you? So this particular QRS complex does not have a preceding P wave. Okay. And what is this particular, abnormal QRS complex? This is nothing but a ventricular premature contraction. Okay. VPC, ventricular premature contraction, VPC. So you have the VPC here. So this ventricular premature contraction, VPC, or even you can say PVC, premature ventricular contraction. So sometimes that can occur in the ECG, okay, commonly with elderly individuals, and sometimes it can occur in a particular rhythm which is known as a Geminy rhythm. So here you just saw occasionally one ventricular premature contraction, but you see there's a ventricular bigeminy as well as a ventricular trigeminy, where in ventricular bigeminy every second beat you have an abnormal QRS. Yes, every second beat you have this abnormal QRS. Whereas when it comes to ventricular trigeminy, every third complex, okay, every third QRS, you are having the abnormality. Okay, so that is ventricular bigeminy and trigeminy. It occurs in a rhythm. Okay, that is called the, the Geminy rhythm. You have the bigeminy as well as the trigeminy. So you see, if you asked yourself the first question, sub question alone, you would have missed this. But it's very important to look the relationship between P and QRS in either way. Okay, so I hope that is very, very clear. So we have answered the first two sub questions. Okay, is each P followed by QRS? Is each QRS preceded by the P wave? Now let's move on to the next question, that is regarding the morphology of the QRS complex. Okay, morphology of the QRS complex. So QRS complex, you will have, when you say morphology, you have to look into the width of the QRS complex, to the shape of the QRS complex, as well as you have got to look to the height of the QRS complex. Okay, these are very, very important. Now moving on to the morphology of QRS. Now let me first show you the genesis of the QRS complex. Okay, first of all, it will be useful to know the orientation of the precordial leads. So you can see that the leads V1 and V2 are predominantly facing the RV. Okay, predominantly facing the RV. The V3 and V4 are predominantly facing the interventricular septum, whereas V5 and V6 is predominantly facing the LV. Okay, just keep that in mind, because we are going to see the genesis of the QRS complex, and subsequently that will help us understand, the morphological abnormalities that occur in case of a bundle branch block, a right bundle branch block or a left bundle branch block. See, the first step, in case of a ventricular depolarization. So firstly, we have an understanding that the first step is going to be a septal depolarization. Septal depolarization, which means you have got the impulse traveling from the SA node through the AV node, then the bundle of His, it is reaching the bundle branches. So the first step in the ventricular depolarization is the septal depolarization. So you have the branch of, the left bundle branch, which is depolarizing the interventricular septum. So always remember, the septal depolarization occurs before the depolarization of the ventricular free wall. So septal depolarization, remember, always occurs in a left to right direction. Okay, left to right direction, that is from the left bundle branch you have the septal depolarization. And you have a look at the cameramen. Remember, I told you about the cameramen V1 and V6. I have already showed you in the previous slide on how the various precordial leads are arranged. So when there is a septal depolarization, remember the direction of the net vector is towards V1. So in case of V1, the septal depolarization will produce a positive deflection. But since it is a septal depolarization, it is a small wave. So you will have the R wave in case of V1. Whereas in case of V6, remember the net vector is away from V6. So it will be a negative wave. And what is the first negative wave? It is going to be Q. So the Q wave that you are seeing in the V6, okay, in this case, it occurs because of septal depolarization. This is again a small deflection, and you will see that many of the textbooks often use, for the normal septal depolarization, they may use the term small q, and they reserve the term the large q for the pathologic q waves. Okay, so q waves can be normal and q waves can be pathologic. So when you have a large q wave, it is likely to be pathologic. Okay, all right. So you understood the initial deflections, the R in V1 as well as the Q in case of V6, and you know why it is a positive deflection in V1 and a negative deflection in V6. That is clear. Okay, so first step was the septal depolarization. Now after the septal depolarization, okay, the next step will be that of the depolarization of the ventricular muscle wall. So before that, let me just tell you, remember I told you about small q and capital Q. What is this pathologic Q wave? Okay, when do you say the Q wave is pathologic? Okay, pathological Q wave. When do you say it is a pathological Q wave? So pathological Q wave means, I told you, a large Q wave is the one that is pathologic. So when the Q wave is lasting more than 40 millisecond, when it is more than 2 millimeter deep, when it is more than 25% of the height of the following QRS, and when it is present in lead V1 to V3. Now remember, you have already having a good orientation of the position of the leads. So you now understood when do you call a Q wave as pathologic. Many of the times you can have a pathology Q waves associated with a myocardial infarction. Okay, associated with a myocardial infarction, you can have pathology Q waves. And you know what? These Q waves can persist because many of the ECG changes in myocardial infarction would revert back to normal. But Q wave is something that would actually persist. So which means, if you notice a Q wave, it is difficult to say whether it is an infarction that has occurred 1 year back or 2 years back. Age determination is difficult. Okay, because it can persist throughout life. So you understood what is a pathology Q wave. Okay, pathology Q wave. Now I'm just going to show you two ECG strips just to reinforce to you what will be a normal Q wave and what is going to be a pathology Q wave. So you look this first example in the ECG, you are seeing some small Q waves here, correct? Some small Q waves are there. Okay, in lead 1, 2. Okay, and so here again, the Q waves are actually very, very small. Okay, in V5, V6, so very, very small Q waves. So these are actually normal Q waves. You can even use the term small Q. Okay, normal Q waves. Now, if you look at the second ECG strip that is shown, here it is quite obvious that you are having, you see this large Q waves in 2, 3 AVF, as well as in V1 to V6 you can see large Q waves. Yes, large Q waves you are able to see. Okay, so it is again an indirect indicator that you have got to have a good look at the ECG to determine that this is a pathology Q wave or a normal Q wave. Okay, so this definitely is pathology Q wave. Okay, this definitely is a pathology Q wave. So you have got to look the ECG closely to make a comment whether it is a normal Q wave or a pathology Q wave. Okay, all right. So the first one and second one is very, very clear for you. Okay. Now in the first one, just let me tell you one more thing. In the lead 3, can you say this is a Q wave? No, because if you look closely, there is an initial positive deflection and subsequent negative deflection. So that is going to be a S wave here. Okay, not a Q wave in this very small one which I have highlighted. So anyway, normal and abnormal Q waves are clear. After the septal depolarization, the next step is depolarization of the left ventricular free wall. You will have a paraseptal depolarization and subsequently a ventricular wall depolarization. Now when you have a ventricular depolarization, ventricular mass being depolarized, remember that the left ventricle is bulky compared to the right ventricle. So the net direction of depolarization, will be towards the left, correct? Will be towards the left. So because of which the next deflection that actually comes in the ECG, when you look from cameraman V1, it is going to be a negative deflection as the vector is going away, and in V6 this is going to be a positive deflection. So V1 you see after the initial R, then there is a S, and subsequently in V6 you have the R wave, okay, because initially you had the Q. Alright, so that is again very clear. Next point is the final step of depolarization, and so the impulse is actually moving from the apical region to the base, and it actually comes back to the baseline. So you can see the shape of the QRS in case of V1 as well as V6. So which is the lead that is more likely to show the Q wave? It is likely to be V6 compared to a lead like V1. Which is why you remember when I talked about pathology Q waves, if you are able to see Q waves in lead V1 to V3, it is likely pathologic. Okay, very important. So another point that you have got to note is that when you move from lead V1 in the direction of V6, the height of R wave actually progressively increases. Okay, because V1 lead, the height of the depth of S is much more than the height of the R wave. But subsequently, as we move from V1, cameraman V1 to V6, at around V3, V4, maybe in this ECG you can say at around V4, there is a transition. And what do I mean by this transition? Transition point is the point where the height of the R wave, okay. So what is a transition point? Transition point is the point where the height of R is greater than depth of S. Okay, that is called a transition point. Okay, so this is also referred to as this progressive increase in the R wave height. Okay, so you see that this is a progressive increase. Okay, so you can call it a R wave progression. Okay, R wave progression. So there is a progressive increase in the height. Okay, so that is called R wave progression. Certain pathologic conditions, can have abnormality here, so you might not be able to see the R wave progression. Okay, so normally this is a smooth progression from V1 to V6. Okay, abnormalities, this R wave progression may be affected. Okay, all right. Now you see here, this is again a normal ECG strip just to show you the R wave progression. So you see, as we move from V1 to V6, okay. So here, what is the transition lead? You can see it is the transition point is at V3, where the height of the R wave is more than the depth of the S. So the transition point usually is at either V3 or V4. Okay, so you are clear regarding the concept of transition point. Now, before we move on to the abnormalities of the the bundle branches and how it affects the QRS complex. Again, just a quick recap of the conduction system. This is AV node, bundle of his, left bundle branch, right bundle branch, the anterior fascicle, posterior fascicle. Okay. So, let's move further. Suppose we have an abnormality like a right bundle branch block. Okay. We are having a right bundle branch block, right bundle branch block, RBBB. So the left bundle branch is intact, but there is some block in the right bundle branch. So we are going to see what impact does it have on the ECG. Now again, let's compare it with the normalcy. Remember, the first step will be a septal depolarization, and I already told you septal depolarization is from the left bundle branch and not the right bundle branch. So here you will have a net direction in this direction. So the same septal depolarization. So here also you will have a positive deflection in V1 as well as a negative deflection in V6, just like the initial normal state. Okay, because the septal depolarization is dependent on the left bundle branch. Okay, that's clear. Now the next step is the depolarization of the ventricular mass. So here again the impulse will travel down, and it is going to depolarize the ventricles. But remember, in the normal state, via the right and the left bundle branches, both the ventricles, left as well as right, were getting depolarized simultaneously. Okay, but here what will happen? You will have the depolarization of the left ventricle, but you see there is no right bundle branch to conduct the impulse. So the right ventricle is not going to depolarize at the time the left ventricle is depolarizing. So yes, there will be a vector in this direction which corresponds to the depolarization of the left ventricle, which is manifested as an S wave in case of lead V1 and an R wave in case of lead V6. Okay, so till this much again it's looking very close to the old ECG. Okay, the normal ECG, okay, not the old ECG. Now what happens is, now you have got to have depolarization of the right ventricle, correct? So, but the right bundle branch is blocked. So you will require the help of left bundle branch to depolarize the right ventricle. So the impulse has to travel in the reverse direction, correct, to depolarize the right ventricle. So now what will happen is that there are vectors moving towards the lead V1. Okay, the direction of the impulse is towards V1, which means the right ventricular depolarization will produce another deflection, and this deflection will be positive in V1 as it is moving towards V1, and will be a negative deflection in case of V6 as it is moving away from V6. Okay. So that will actually create an RSR dash pattern, okay, RSR dash pattern in V1, okay, almost the shape of a M, correct, no? Almost the shape of a M, and in case of V6, it is almost the shape of a W, okay. So that is again very, very clear, okay. Alright, so that is what happens in case of right bundle branch block. So once again, just to reinforce, in RBBB right bundle branch block, in case of V1, there will be a RSR dash pattern. Some people, use this with small r, S and R dash, because the second R, you will have a larger R wave. So that is capital R, the initial one is small r. So this is an RSR dash pattern, okay. So that will be a M shape in V1 as well as a W shape in case of V6. And remember the S wave in case of V6 in case of right bundle branch block, you will slightly see a slurred S wave also. Okay, you will slightly see a slurred S wave also. So this is what you see in case of right bundle branch block. Okay, alright. So just to show you right bundle branch. So the right bundle branch block, here again you can see the M pattern in the V1 as well as when you move to V6, okay, you are seeing the slight W pattern. Q wave is there, you can observe it closely if you look. Okay, sometimes it might not be very obvious the W pattern in V6, but the M pattern is what is more striking. So when you have a right bundle branch block, what will happen to the morphology? Remember I told you there will be change in the morphology and duration of the QRS complex. So you will be looking for the width, the height, and you will be looking for the shape. So the point here is the normal QRS complex, it is less than 120 milliseconds. You can roughly say it is around 80 to 100 milliseconds. Okay, the normal QRS. So in case of the bundle branch block like RBBB, so in pathology what will happen to the duration of the QRS complex? It will increase, it will be more than 120 milliseconds. That is more than 3 small squares. It will be more than 3 small squares. Okay, right bundle branch block. Okay. Alright, so that is again very, very clear. Okay. What are the conditions, okay, or the causes of RBBB, right bundle branch block? What are the causes? So right bundle branch in comparison to the left bundle branch, it is a very fragile conducting system. Even in Braunwald textbook of cardiology, they also use the same word. It's a fragile conducting system, right bundle branch. So it is more likely to be affected by, smaller injury also. So sometimes you might see in perfectly normal physiological state also you might see a right bundle branch block. So remember, RBBB is not always pathologic. It may be physiologic as well. And other conditions like right ventricular hypertrophy, pulmonary embolism, ischemic heart disease, myocarditis, cardiomyopathy, these are some of the causes of a right bundle branch block. Okay. So you have understood what is a right bundle branch block and what impact does it have on the shape of QRS, the morphology of QRS, and what are the causes of a right bundle branch block. Next we are going to see regarding the left bundle branch. Okay, so it is having an anterior as well as a posterior fascicle. Okay, so either the left bundle branch per se can be blocked, where you call it a LBBB, okay, a complete LBBB, or you can have a anterior fascicle block or a posterior fascicle block. So if it is a anterior fascicle block, you will call it a left anterior hemi block. If there is a posterior fascicle block, you will call it a left posterior hemi block. So when you have a LBBB, just like RBBB, here also the duration will be more than 120 milliseconds. But in the hemi blocks, you get partial LBBBs, okay, partial LBBB. So the duration may be in the tune of say 100 to 120 milliseconds, because you can say roughly around 80 to 100 is normal. So this is called incomplete left bundle branch block. Okay, that is with the hemi blocks. So left anterior hemi block, LAHB as well as LPHB. This will also be associated with axis deviations that I have discussed in the where I have discussed the axis. I have told about that point. So here you will have the left axis deviation, and LPHB you will have a right axis deviation. Okay. Now let's learn more regarding left bundle branch block. So regarding left bundle branch block, so remember when you take into account the steps of ventricular depolarization, the first step was that of the septal depolarization. So septal depolarization, remember, normally it would come from the left bundle branch and it is coming in a left to right direction. But here what is happening is there is a block in the left bundle branch. So now what will happen is that the septal depolarization will be via the right bundle branch. Septal depolarization via right bundle branch. So the direction of depolarization will be again ulta, that is from right to left, because of which, unlike the normal state, you will have a negative deflection in case of V1 as well as a positive deflection in case of V6. And always the first negative deflection is always a Q wave and a positive deflection is the R wave. Okay, that is clear. So that is the septal depolarization. Now once the septum is depolarized, next is about the depolarization of the ventricular muscle wall or the free wall. So here you have the blockage of the left bundle branch. So predominantly what will happen is that you will have the direction of impulse propagation from again to the right side of the heart. Okay, to the right side of the heart. Now since it is moving towards the right side of the heart via the right bundle branch, the next deflection is going to be positive in case of V1 and negative in case of V6. So it is going to be R wave in case of V1 and S in case of V6. But here it will be a smaller deflection because the right ventricle compared to left ventricle is a smaller sized one. So smaller deflection. And then what will happen? Once the right ventricular wall is depolarized, subsequently you will have to have depolarization of the left ventricular free wall, for which the impulse has to go in the opposite direction, in this direction. So now it will go away from V1 and towards V6, which will produce a negative deflection in V1 that is the S you can see, and a positive deflection in V6, that is the R, and subsequently it reaches the baseline. Okay, so what you can see is that in case of V1, definitely the duration is prolonged, no doubt about it. Okay, the QRS complex duration is prolonged compared to normal. Now remember, when I use this term normal QRS duration, normal QRS is normally narrow. Okay, so don't think that when somebody uses the term narrow QRS, because in tachycardias you will be having this term narrow QRS tachycardias, which means the QRS complex is normal, normally narrow, whereas the abnormality is the wide QRS. So once again, coming back to this, in V1 this will have the shape of a W, and in case of V6 it will have the shape of a M. Okay, so sometimes the W might not be appreciated, it might be a single negative wave like this, and you might call it the QS. Okay, this is the QS complex also you might call it, okay, or a QS wave. So here you can see in case of left bundle branch, W pattern in V1 and M pattern in case of V6. The wide and deep S wave, I told you sometimes QS waves, you can see it. Okay, they'll be together, you might not be able to appreciate the W very much. And you can see the V6 M pattern, a notched R wave, M shape you can see in case of V6. And this is a patient having a complete LBBB. Okay, how do you say it is complete LBBB? You can see the, the duration of the, QRS complex. When it is more than 3 small squares, you say this is a wide QRS complex. Okay, and 100 to 120, it is incomplete LBBB. Okay, that is again very, very clear. Now the causes of left bundle branch block. Okay, causes of LBBB. Let me tell you one thing straight away, that RBBB, I told you, the fragile conducting system, so that can be physiologic also, but LBBB is always pathologic. Okay, it is always pathologic, so it can be associated with ischemic heart disease, okay, aortic stenosis, hypertension, dilated cardiomyopathy, all can cause left bundle branch block. Now another point that you must know is that these causes for wide QRS, the right bundle branch and the left bundle branch block. So this LBBB, RBBB, they may be associated with secondary STT changes. Okay, we learn about that in case of the ST segment as well, but understand that there can be secondary changes. So which means if the QRS complex is wide, the associated ST changes, because even in case of the LBBB, you can have some sort of a ST elevation. So, then you will have to determine, is this STT changes secondary to the primary QRS abnormality, or is there a separate abnormality there? However, if you have a normal or a narrow QRS and then STT changes, it is likely to be a primary abnormality involving the STT region. Okay, so I hope that point is very, very clear. So all this might be associated, LBBB might be associated with the secondary STT changes. Now just once again summarizing, comparison of normal versus RBBB, LBBB. You can see the shape of the QRS in case of V1 and V6. And in case of RBBB, the M pattern in case of V1 and the W pattern in case of V6. And in LBBB, the W pattern in case of V1 and the M pattern in case of V6. So these are the most important points with respect to analysis of the QRS complex. Always remember, first of all, try to see if there is, try to see the relationship between the QRS and P, and subsequently, once you have answered the 2 sub questions, you try to see the morphology of the QRS, okay, the width, the shape, the height, okay, that's how you will analyze the QRS complex, okay.